Okay, welcome everyone. Can everyone hear me? Thanks. My name is Kristoffer Hals. I work for dScience, and welcome to our lunch seminar series. Today we are pleased to have Hedvig Nordeng with us. Hedvig is a professor at the Department of Pharmacy at the University of Oslo. Today she will share her experience with developing data analytical pipelines for Norwegian linked health registry data to answer public health questions about the use and safety of pharmaceuticals. So please go ahead. As usual, we'll do Q&A after the talk, and we'll have a microphone that will be passed around. So yeah, think about some smart questions. Not yet. Hold your horses. Okay. Please go ahead. Thank you.
Thank you so much. Can everyone hear me? Yes, that's perfect. Okay, so it's my pleasure to be here today with all of you to share some of my experiences, but also that of my colleagues. And I would like to start by acknowledging that we are a team, and the experience that I will be sharing with you is due to that common teamwork, not only by colleagues at the Department of Pharmacy, but also from our colleagues at the Department of IT, which have been crucial for the e-infrastructure that we are using. And just to start off, I'd like just to ask, so I can understand a little bit who's in the audience. So how many of you are or have some experience working with Norwegian registry data? Yes, of course, so my colleagues here. But it's a kind of a mixed group. And that's great. Now, let's see. Now, as you all will know, that Norway is home to some of the world's most comprehensive and well-maintained health registries. And these registries, they include a vast amount of information about patient demographics, about their diagnosis, about their treatments, whether it's pharmaceuticals or others, and also on outcomes. And therefore, jointly, they present a huge opportunities for researchers to gain insight into both the effectiveness, but also the safety of pharmaceuticals and also vaccines for patients in the real world setting. And then what is the real world? Well, the real world is every kind of setting that is outside the randomized controlled trial setting. And so in this presentation, I will address and share with you some of the experience with Norwegian health registries, but also with some of the really amazing birth cohorts that we have. And I'd like to give you also an overview of how we generate real-world evidence for regulatory purposes. What are the challenges and what are the solutions for translating data into action? Because we want our studies to be regulatory applicable. And I'll show you some examples of our research, but also talk about then the data analytical pipeline that we have developed. And all of this is made possible because we have in Norway, as we have in the Nordic countries, we have a personal identification number. So this personal ID number, it enables us to link all these registries together. And then just going back a little bit earlier this year, some of you might have attended the Life Science Conference here at the University of Oslo, where Boston Consultant Group, they presented their report on health data and public-private partnership, how competitive is Norway. And they concluded as follows. If Norway wants to lead the health data and realize very many of the opportunities that come with it, it will require collaboration, investment, and great efforts. Government, academia, and industry have to collaborate on initiatives that will yield immediate impact and significantly strengthen healthcare, research, and the life science industry. And the picture is a picture of the head of medical evidence in AstraZeneca, and he says, look to Finland. And I would really think that our ambition should be look to Norway, look to University of Oslo. So how can we jointly enable that? Why is the industry interested? Well, we're seeing that real-world evidence, real-world studies are actually have an impact on regulatory decision-making. Both the FDA and the EMA, which is the European Medicines Agency, they are now basing also drug approvals on data from observational study. So there is a great push also from the pharmaceutical industry to actually collaborate with us. And we've been doing this for decades already. In the Nordic countries, this is what we have a long tradition of collaborating. We share many of the same registries, our society and structure share many similarities that makes it easier to collaborate. So jointly, if we see our entire Nordic region as one cohort, we cover almost 30 million inhabitants, and here over 280,000 births per year. And because of our data isn't that different, it is easier, I would say, to structure them in a common way, using a common data models. And we're also actually able to pool data from Norway, Sweden, and Finland here at the University of Oslo, so we can analyze the data sets jointly. For Danish data, it's a bit more complicated due to some of their regulations. So Danish data needs to stay in Denmark. So we would write the scripts, and then we would send the scripts off to Denmark, and then we would use a meta-analytical approach to combine the effect estimates. And here's just one example of a study where we used this approach, where we wanted to investigate whether a certain antibiotic drug could increase the risk of childhood cancers. And as you know, childhood cancers are rare. Therefore, it was important for us to use data from all the Nordic countries. However, this study, it took us 3 years to get all the approvals, to structure the data, to write the scripts, and to perform the study. When there are urgent public health questions, like we've seen in the pandemic with some of the COVID-19 vaccines, like with the AstraZeneca vaccine, we cannot wait for 3 years. We need to go much, much faster. And how can we do that? And how can we, at the University of Oslo, be part of that? So for real-world data to be regulatory informative, we need it to be fast and transparent. We need it also to be representative of the EU regions. It's not sufficient only to have Norwegian data or even Nordic data. We need it to be representative of all of Europe. So commonly, the European Medicines Agency will ask for at least like 5 European countries of diverse location. So with good geographic spread. And the studies, the analysis, they need to be reproducible, replicable, and they need to be robust. And in the European setting, so I'd just like to spend a few minutes on how the European setting is when it comes to surveying drug safety issues. And it all it's really this life cycle process. So it's not like when the market authorization holder, the company, gets a market license, it's put on the market, and then they say, okay, whatever. No, there's a life cycle approach of surveillance. At the time that the drug is put on the market, every drug will have a risk management plan. And in that plan, there will also be tailored out the areas where we lack information on safety issues. And there could also be requests of additional studies that actually the company needs to do. Then the drug is put on the market, it is used by our entire populations, and this is where we need to survey. And we have a term for it in English, which is called pharmacovigilance. This is something that we also teach at the Department of Pharmacy, which is the methods and the ways of how to survey the safety of pharmaceuticals in the real world, whether it's through spontaneous reporting systems or via targeted studies. And in this way, we will generate more knowledge, and we will get a better characterization of the risks of the medications. Thereby, the evaluation of the benefits and the risks could be better informed. Now, when we see safety signals, and there are concerns out there, there will be an immediate call potentially for action, and this is where we operate in the risk minimization. There might be severe concerns with medications, but we can put in place measures to minimize those risks. And of course, if the European Medicines Agency, if there are risk minimization measures put into place, these also need to be evaluated. And for example, if a drug receives a restriction and indication so that certain patient groups should not be using the drug, then what we in our studies would expect to see is a decline after the intervention. So the policy would be the intervention, and then we would expect to see a decline in use in that drug in that certain population. So that's information that is important for regulators. So it's really this circle of evidence. And the committee that is responsible for surveying drug safety in Europe is called PROC. It's the Pharmacovigilance Risk Assessment Committee. And this committee is responsible for the monitoring of all, as I said, safety issues, which includes detection, assessment, minimization, communication about adverse drug effects. And the committee is also responsible for commissioning audits or new studies. In this committee, all 27 member states have their representatives, but there are also 6 EU commission-appointed experts, and I am one of them. So I get to see actually behind the scenes and see parts of the discussions that are happening at the commission level. And just to give you a glimpse of how it looks behind the scenes, this is how it looks. So we meet up every month, and here we discuss the safety signals, the concerns that we have in Europe, and decide upon what is what is a risk-proportionate action. And also gaining this insight has been also important for our group, really to be at the cutting edge, also with the needs from regulators. Okay, so some of the challenges from a European perspective has been that there is a lot of data out there in Europe, but it's extremely diverse. And this diversity, it brings a lot of challenges in terms of having a common data structure, having a common terminology Like we use ICD-10 codes. In the UK, they will use READ codes. Others will use SNOMED codes. So even our languages and coding system is very, very different. How do we harmonize that? And governance. And as of today, it is hard. It's actually hard to get access it's hard to get fast access to data. And all the regulatory processes are slow and complex. So currently, in every country, everyone is sitting coding their own scripts on their own data. And this is extremely inefficient. So you can think of it as is visualized here, and that it is not scalable, it is not transparent, it is not reproducible, it is expensive and slow. So if our ambition is to increase productivity up to really an industrial level, it really requires automation of the analytical processes. And it requires a rigorous standardization of how we present the data. We need full interoperability of the data with respect to the structure and the coding systems. And to do so, we need to use a common data models. Now, how many of you are familiar with using common data models in your work? Yes? Yes, so I also see even from like biological science. So this is not unique for pharmacoepidemiology, but yes, so it's the same. We need to structure data so that we can analyze it in a common way. And we need to do so for all kinds of studies. So currently, we are doing one type of studies for drug utilization. There's one for disease epidemiology. To know that something is sick, we need to know how it looks like when it's not. For example, now with the menstrual bleeding after the COVID vaccines, we know what is the prevalence, what is the normal prevalence of menstrual disorders or bleeding disorders in our population. We need to know. So we need to know what the baseline is. So we need to go from here over to here. How can we do that? By using the common data model, and there are many of them. And I will show you just some examples. I'm not passionate about common data models. Some are. So like data scientists will be. To me, a common data model is just a tool. I don't care whether I use the OMOP common data model that I'll show you, or whether I use the Nordic common data model or conception. I want to be flexible. I want to be flexible to work with all the great researcher groups in the world, and it is just a tool. However, it does split the process into two segments. The first is really the data standardization, all the preparedness, and this is really where the data analytical pipeline that we have at the university, all the investments. And I know that some colleagues here are thinking about the same, and I think you asked me, was it worth the effort? And I would advocate, yes, it is worth the effort, putting the time and energy into that data standardization. And this is also where we've had great support from the IT department and from data scientists and data engineers. And then when you've done all that investment, then you have a separate, the analysis phase and the execution. And here, this is just a visualization of how you can do it. So you have your source data. You develop your ETL script. ETL is extract, transform, and load. So you need to have your script that transform all your heterogeneous data into that common data model. And on that, you run your quality checks. And that sounds really easy, but it's a process that took us, the first time we did it, it took a year. Yeah. Okay. This, the OMOP, Common Data Model, and the work that we have invested has enabled us to become part of this network. And I'll tell you a little bit more about the Darwin network, because this is really the project that aims to transform the use of real-world data for regulatory purposes in the EU. And this is also very linked in and linked up against the European health data space of sharing and collaborating, forming networks. This is how the Darwin EU system works. So it's a network of these data partners, but equally important is it's not only the data, but it's the expertise, the know-how, how to get the data, how to transform. So I would say the data expertise and the expertise that my team and I have over like a decade is equally valuable. And this is how it looks. So there's one coordinating center, that's the University Medical Center in Rotterdam. There are now currently 20 data partners all across Europe. And we, at the University of Oslo, we're representing Norway in this network. And actually, then you see the committees, like the European Medicines Agency and the different committees under the, like PROC, which I mentioned, and the committees can ask for studies. So the principle is that the data stays local. The data never leaves the University of Oslo. It never leaves TSD. These are sensitive health data, and we do not transport anything outside the TSD. We use the OMOP Common Data Model, and then the scripts, the study packages, are programmed by the coordinating center. We all data partners have our data structured, well prepared, so that when they push the button, we can go. And yeah, so this is something, the speed is new to us, but very exciting. So this is just a visualization of how we have done it here at the University of Oslo. Our data analytical pipeline. So here you see like a representation of what kind of data do we have? What do we need? So we take data from the Statistics Norway, that's like demographic data. We have data from Kur, which covers the primary care, everything that happens at the GPs. We have the Norwegian registry data, which happens everything that happens in hospitals, all kinds of diagnoses, interventions. We don't get actually drug dispensing in the hospitals. So we don't have everything. The Norwegian prescription database, which for us is a core registry, because there we have information about all drugs that are prescribed, not only prescribed, but actually dispensed to patients in the outpatient setting. We don't have OTC drugs, like over-the-counter drugs. Then we have the medical birth registry, which covers information about all the births and pregnancies. And I'll go into that because that is a special area of interest for us. We have the registry of communicable diseases that is called MSIS in Norway. So all kinds of infections, and during the pandemic, this was crucial, having information from MSIS here on test positives, test negatives for COVID. And then we have the Norwegian vaccination registry, SYSVAC, where every vaccine is recorded as well. And we don't map all data. We don't do that. because that would be like just too much. So we have gone through and selected those variables that are most useful for the kind of studies that we do in pharmacoepidemiology. And those are the variables that we have mapped onto the OMOP common data model. And it will enable us to do like disease epidemiology studies, drug utilization studies, drug safety studies, and also vaccine effectiveness. So these are kind of the core types of studies that we do. And just to, we have several data sets where we link and combine. So in some we have everyone, like the entire Norwegian population. So you guys are in there. And in some, we will only have, for example, the pregnancy studies, we will only have, we will start off with the birth registry as our source registry. And just to give some examples, so in the data set where we have the entire Norwegian population between 2018 and 2021, there are over 250 million drug exposure. So this is a vast amount of data. Yeah. And the way that we get to this data, now traditionally we would develop a protocol. We would send that protocol to the ethical committee to get ethical approval. We also, at the same time, we would send our application through Helsedata Norge. So this is the portal that we now have that's run by Helsedata Service. And they actually can grant approval for the exemption of informed consent for very, very many of the national registries that we have in Norway. We need to decide on what is our source registry, and from that registry, there is created a project-specific ID. And from that is sent to all the registries. They pull out the data, they add the project-specific ID, and they take away the personal identification number. So we never receive any personal identification numbers. And then this all gets sent to the university, and it's sent directly into the TSD. We do a data protection, what does the I stand for? Investigation assessment. It's like the DPIA. That is how that we handle the data with care. We do that together with our data protection officer. Yes, and it's stored at TSD. And just one example from one of the studies we did. Now, this one was published a little bit earlier this year in Lancet Respiratory Medicine, which is in medicine one of the really high-ranking journals, where we assessed the effectiveness of COVID-19 vaccines on their ability to prevent long COVID. And across different cohorts with different characteristics, we saw that jointly the COVID-19 vaccines reduced the risk of post-COVID conditions by 62%. And I'd like to acknowledge the work of my colleague, Nung, who did like an amazing job here. Okay, so a little bit back to Darwin. What will the Darwin network deliver? And there are different categories of studies. There will be off-the-shelf studies. It's really like fast, routine studies. There will be complex studies that will take more time. I'll give you some examples. I'm not actually quite sure what the routine required analysis, but I think that's just like repeated. You just update the analysis. And then there's very complex studies which may include primary data collection as well. Here's some examples. So off-the-shelf studies, that could be like the prevalence of disease or the background rates of certain adverse drug reaction of special interest. And it could be like a natural history or a prognosis of some disease. incidence and prevalence of drug utilization over time, etc. More complex studies could be the evaluation of risk minimization measured, like does policy impact a certain drug utilization pattern? If a drug is contraindicated in pregnancy, do we see the decline? Yeah. And then different kinds of study design, which are more complex. And the study we will be starting off this next month. First, it's going to be really exciting. It is a study on the effectiveness of human papillomavirus to prevent cervical cancer. And we know that the HPV vaccination programs, they have shown to reduce not only the HPV infection in itself, but also cervical cancers. But we need to know, is that true also in the real world, not only in the trials? And this is really the aim of that study, and we will be collaborating with at least Spain and I think the UK, and then we are the third country. So that's going to be exciting. What we also do is we also see opportunities for collaboration with the industry, and we take on, when it aligns with our own research interest, tenders. And this is my colleague Angela Lupatelli, who's heavily involved in these studies with not only like Pfizer, but Moderna, etc. So she's running, and not only she, but many of our colleagues here are involved in vaccine studies, and then also different kind of studies for the pharmaceutical industry. And it gives also a good opportunity for funding. And as I said, when it aligns with our research interest and when we feel we have the capacity. Currently, we do not have the capacity to take on more, but there might be opportunities in the future. How am I on time? Am I okay? 5 minutes? There's so much more I wanted to tell you guys. Okay, 10 minutes, yeah, because I do want to leave time for discussion. Because where my heart is. Now, it's for vulnerable populations that are those that are routinely not included in the clinical trials. Pregnant women, children, the elderly, the frail. This is a specific focus of our research group. And just to ask you, like today, how long do you think it takes, in average, before we have enough knowledge about whether a medication is safe during pregnancy? I'm going to ask our guest researcher from the UK, Peter, would you like to guess? 20 years. Pretty good guess. Pretty good guess. Anyone else? Okay, it's pretty close. So today takes about 27 years before we have enough evidence that we could say, okay, we believe this drug is safe. And can you imagine, like, how do we treat pregnant patients today? So how can we take those 27 years, how can we reduce it to 2.7 years? Or maybe let's say 2 points. How can we reduce that? I would advocate that it's not acceptable. For example, during the pandemic again, could pregnant women take COVID-19 vaccines? You know, we cannot wait 27 years for that. And this is also, this knowledge gap, it is translated into the package information. So what patients read. And here's just a copy of one. This is very standard. This is from a migraine drug. So many women of reproductive age, they have migraine and they want to know, can I use my migraine drug during pregnancy? And they will often see text like this. There are a limited amount, and they will refer to animal studies. Now, animal studies can be useful, but they can never replace human data. So again, going back to the European initiatives, like how can we're not going to be able to solve the 27 years in Norway, but we can do it maybe in Europe and maybe globally. And this is just an overview of registries and birth cohorts in the European countries. And now, 4 years ago, we received joint funding from the Innovative Medicines Initiative to join forces to make a platform for the next generation of studies on drug utilization, drug safety, and pregnancy. Can we make a platform for this? Can we end this 27 years? And this is a joint initiative not only from academics, but is equally from the industry and from regulators. And here, it's not only use of secondary registry data, but it's also those primary data. It is also colleagues working with animal models. Can we make better animal models as well? And even clinical studies of breast milk transfer. So because we had this network, when the pandemic hit, we could mobilize. We could get everyone on board and say, okay, what do we need to do to actually answer the questions about not only like COVID vaccines, but also about all the medications that might be needed to treat COVID-19 in pregnancy. Okay, and I'm going to jump fast forward because I do want to talk about like some of the birth cohorts where we can use just one slide back. Beside the registries, we do have in Europe large birth cohorts, and we have one of the largest in Norway. So the Norwegian mother, father, and child cohort. There's a similar one in Denmark. And in this cohort, over 100,000 pregnancies are followed with detailed questionnaires, but also biological samples during pregnancy. And we could link that to our national registries, and that is what we're currently doing. We could jump a little bit. This is one example. Here, to UIO Real Art, which is our convergence environment. So we have all this real-world data, but we also need to work with simulated data sets where we actually know the ground truth. And this is one of the projects that's really, and I'm excited that I'm seeing some of my colleagues here. You will see your picture up here, where we join forces and where there is a strong focus on computational and machine learning methods. So I do believe this is the way forward. And just very quickly about training of scientists. We have formed an international alliance because we want to also to work specifically, also not only go broad, but also go deep, and to try to understand some of the underlying molecular mechanisms involved in, for example, drug toxicity. And we have funding from the Norwegian Research Council for this international alliance, where we collaborate with some really great research environment, focusing on methodological work, focusing on clinical work, like clinical teratology, and then also a third work package on execution of the studies. And as I mentioned, training, this is one of the courses that we offer at the Department of Pharmacy. And maybe just to end with this slide, because this is a slide for all of us. Looking forward, where do we go from here? How does the new life science building, how can that act as a boost? How can it get scientists together? How can the Oslo Science City be, I heard the word gravitation center used, all these different words. And I do see that this is an opportunity for Norwegian researchers, but also in terms of like research, but also education and innovation. And here there lies also some important funding opportunities. And with that, just a picture for one of our trips. So thank you for your attention.
Thank you very much, Hedvig. Very interesting presentation. Do we have any questions from the audience? Yes. My microphone is going to come up.
Yeah, hi. I am a PhD student and I work with machine learning with medical imaging data. And what I realized is that a lot of my 70–80% of my time is spent doing data transformation and everything that you need before you can train a model. Everyone is doing the same thing. And then sharing those data sets is really hard, like you said, because we don't do this, we don't put them in this common data modeling as you guys do. And I think that's mostly because who should do that? Like, is that a PhD student? We don't have time to do that. If it's someone else, where do you get the funding? So who's that person who has done that for you? How did you get the funding? How did you manage that?
It's a great question. So we actually got a specific funding. We got 1 million crowns from a scheme, a European scheme, to actually to do the work with transforming our data, so building the ETL and transforming it onto the OMOP, Common Data Model. So you're right, you need specific funding for that investment. Yeah. Now, what we have done is, because it's a continuous process, so what we do now, so we've created a national node for all those partners working with the OMOP, Common Data Model. And then when we see the need for updates, we share work. And we need, for example, we need to map now something called varenummer. It's like super boring work, but it's important because we need to be able to distinguish between different brands of vaccines. So maybe we cannot take on all of that work, but can we divide it? So we can do some, the cancer registry can do some, and even some of our colleagues in the other Nordic countries can do some. Yeah, but I think one PhD student, then yeah.
But the grant you got was just for your group, or did you collaborate with other groups too?
No, that was just for our group. Yeah.
Okay, another question up here. And one in the back after.
Great presentation. From your presentation, it was clear that the ongoing efforts for standardization would really accelerate the capabilities of having useful insights from those various analyses. But one thing that wasn't clear to me is the extent this might also accelerate the existing gap between different geographic areas in Europe in their capacity to really ask similar questions, because I'm not sure whether or not countries more at the periphery with less resources, for example, computational-wise or even expertise-wise, would be able to take advantage of this existing infrastructure. And actually, on the opposite, the fact that they standardize their own data models makes them easier to be exploited by existing leaders in Europe, because they would be able, those countries like Norway would be able to boost the power of the studies by taking advantage of this now more easily available data. So are there, let's say, policies to more easily even out the expertise and the resources so that other parts of Europe might also be able to take advantage of that, given that they might be lagging behind in their capacity to make those questions?
Yeah. No, I think it's, again, a great question. And I alluded to it briefly, saying how important geographic diversity is. And you are right. Currently, the Nordic countries are very strong. We have an international advantage now. That advantage is going to disappear because other countries will catch up, and it's good. we're seeing that countries in the Eastern Europe are lagging most behind, but Southern Europe, there's like great databases and great expertise as well. So it's something that the European Commission is very well aware of and trying to support by different grant schemes. Yeah, and absolutely the European Medicines Agency in the Darwin network are trying to bring on board more data partners from Eastern Europe. Yeah, some of the problems is that not that many countries have the entire country, but that's okay. You can have like a region. Yeah, that's okay. Yeah.
Rein, you had a question?
Yeah, I'm Rein Osland, Department of Bioscience. I commend you on the work you've done here because you may know that I have been involved in another parallel kind of thing in bioinformatics data, genomics data, and so on in a European infrastructure program called Elixir. Some 15 years ago, people were, when you described here, saying, because it's boring to do this standardization and so on, but they realized it's going, because so much work in bioinformatics data has been wasted, because people do it only for themselves, and it's going to be wasted and obsolete. So now 11 years in the working, EU has funded a pan-European infrastructure program to do these things, precisely what you asked PhD student on the first row, you asked, so that you don't have to do these things alone. And this is going on. And it's in life science, and they are now merging, bridging out to talk to other. I see that your people have been very close to Elixir people on meetings and so on. And I know, biodiversity data is another branch coming in, and of course, medical data of all kinds. And Norway has been very active here. The TSD thing you point to, that University of Oslo, USIT has been creating, is the core part of this. The FAIR principles for fair sharing. This grew out of Elixir as a need, because it was the only way to do this. So I commend you and congratulate you on so this federation that you said. Elixir launched the federated genome-phenome data in February, and the first data sets were in from Norway already very soon after. So this is a big, I think, movement in all of Europe, and it's not a competition between countries. It's an all-European and actually a global effort.
Yeah.
There is a global effort on the same thing with life science data, which Norway is also participating in. It's called the Global Alliance for Bioscience Data. Who's going to pay for this and ensure that the data will be available in the future? So congratulations, and we should talk.
We absolutely, thank you so much, Rein. And just as a comment, we have learned so much from all the initiatives working with non-sensitive data and taking those lessons learned over to use on sensitive health data as well. So that's Elixir, as you said, is super exciting. Yeah, thank you.
It's a lot about sensitive data as well.
Yes, it is, absolutely. Yeah.
Thank you. Yeah, I think we can have one final question there. Arash?
Hello, thank you for a very interesting talk. I'm thinking of the part that you were least passionate about, the data models and the data transformation part. Do you think it's more efficient to actually inform the developers of the data model about your data structure in a synthetic data format, and then let them either develop a pipeline for data transformation or give you a recipe to do that?
We did so in the beginning, where we started off. We gave a company that was used to doing the ETL process, we gave them information about all our data structure. They developed a simulated data set, and they helped us. So that was what we used some of the funding for. However, now we are also seeing limitations with the OMOP common data model, and we are now feeding back to them where improvements need to be made yeah. So it goes, I think it's a circle. But we got help in the beginning. Now we're feeding back, and I'll give one example, and that is we saw that this common data model was not fit for purpose to do pregnancy studies. So now we have launched an initiative where we are asking for, we call it a pregnancy extension table. Yeah, so it's a collaboration, ongoing, yeah. Thank you.
Thank you. Okay, one more question.
Oh, we can't. Yeah. Oh, yeah. Feel free. I'll stick around and.
Okay.
Oh.
We don't have time for more. Okay, then we don't have time.
I'll stick around. Yeah. Yeah.
Okay, one round of applause. Thank you, Hedvig. Thank you so much. Okay, that concludes.